I'm very pleased to have a webinar together with all of you today, and I quickly want to introduce our today's program. It consists of a presentation from Stefan Griesbach and myself, and we don't want to lose a lot of time with the introduction. Hopefully you have a very interesting meeting with us. So let's start, and I hand over to Stefan.
Yeah, thank you very much, Saskia, and also from my side, a very warm welcome to all of you. As you saw in the program, we're focusing today on genetic tumor diagnostics and our genetic tumor diagnostic services. So I will be happy to give in my first part of this webinar today an overview about the services we can offer to assist you, your patients, in choosing treatment options. And Saskia then subsequently will give you a little bit more broad overview about how to integrate that on in the patient's everyday life. So as Saskia mentioned, we are looking very much forward to have you here today. Generally, I would love to start off with giving you a very short overview who we are and where we're coming from. So CGAT focuses on genetic diagnostics from the very start. And generally speaking, we have two different kind of setups. We have on the one hand, Germline Diagnostics, where a gene variant can cause a serious disease in the particular patient. And on the other hand, which is our focus today, we look for somatic variants that determine the effectiveness on a cancer treatment for the particular patient. We can identify additional options for this cancer patient in treatment. In order to ensure the highest quality which we are inherited in our setup, we want to have full control about the whole process. So we have, on the one hand, the laboratory where we start off with sequencing all relevant genes. We here have our own design on the enrichment kit in order to streamline that, to optimize that, to get perfect coverage on our target regions. We then have our in-house bioinformatics, which enhances the data so that it can be used in the diagnostic setup in a way that we don't lose any valuable information on the insides of the tumor. And then we have a highly educated medical interpretation team consisting of many, many scientists who in detail each individual case evaluate in order to ensure that we don't miss anything on here the treatment options. So as a company, we have been founded back in 2009, in fall 2009. So roughly about now, we have our 12-year anniversary. And from the start, the best possible quality was a big thing for us. So therefore, we started immediately working on our accreditation, and we acquired our ISO accreditation in 2011, which is about 1.5 years after founding the company. And I think that's roughly the minimum time frame that is needed. Interestingly enough, still today, ISO accreditation or accreditation in general is not fundamentally mandatory to do this kind of genetic diagnostics, at least in Germany. Still, we are strongly believing in that, and when we moved more and more internationally, we saw that CAP and CLIA accreditations, the US norms, are also very well received, and even so they might not differ in the quality overall, it's a different kind of accreditation. So we acquired these in 2016 and 2017. As you see on this picture, somatic tumor diagnostics was not there from the start. So we started in 2010 with germline panels for epilepsy and retinal diseases. But we very fastly saw that tumor diagnostics is very interesting in the field of genetics. And so we introduced somatic tumor diagnostics as early as 2013. So that's now about 8 years ago. This actually is us on our 10-year anniversary, where the world was still a little bit more relaxed, and you actually could have a big crowd like this coming together and celebrating our 10 years. Today, we're looking at our company in about having roughly like 300 employees, a little bit more right now. Young, highly qualified team using the latest technologies. Again, we are striving, and it's our strong belief that the best diagnostics is the one that every patient deserves. When we look on our overall service overview, we have on the left-hand side our germline part, which is CGAT panels, dedicated gene lists that are curated for specific phenotypes, like, as I just mentioned, epilepsy diseases or retinal diseases. We have them for many different more. We then have our CGAT exome extra, which we believe is the best exome diagnostics that currently is available for patients. But again, today we want to focus on genetic tumor diagnostics. So assisting patients, assisting you oncologists in treating, making treatment decisions for the patients. Our vision when it comes to genetic diagnostics in cancer patient management is that, first of all, every patient deserves to get the diagnostics which is according to the recent literature, according to the highest quality, and that we should include and incorporate all research that is available in standard of care services for each individual patient. In order to do so, as I mentioned before, all of the steps we are doing are done in-house, and we have 100% control about these processes. But then we're also believing in a very holistic approach. First of all, that we see that, or we striving our tumor diagnostics to incorporate as many markers as possible for each individual patient. But then we also believe that they should be incorporated in a setup of experts. So not only the genetics, but we need to see the radiologist, the oncologist. We need to hear everybody, and last but not least, also the patients themselves, in order to choose which is the appropriate treatment for that particular patient. So all of that together, we think, is an approach that benefits the patients best. Why we are still here is that, and that is a picture I actually was thinking I was not would need today any longer when I first saw that from a presentation of Saskia, I think back in 2015. So here the widow gets told by the physician that the husband was dying in compliance with standard of care simply because we didn't know better or we didn't do better. And again, I was hoping that this was something that we would overcome in the next couple of years, and I think we are at a good way to do so. Still, it is sadly still very much common. So where we think we should be is that every patient should receive personalized precision medicine targeting the individual characteristics of the tumor and incorporating all individual characteristics of the patient. So what we're looking for is, so why genetic tumor diagnostics? What do we see? Generally, it is done today, but most of the times very limited. For example, we look when we have a lung cancer patient for EGFR mutations. If they happen to have that, we have a dedicated treatment for that. We also look for ALK translocations. If a patient has that ALK translocation in the tumor, we have a dedicated treatment for that, or breast cancer HER2 amplifications, and so on. Still, we're starting off with what cell the tumor originated from, and not what are the molecular diagnostics. They come in the second line. So where we think we should come to more and more is a change of the paradigm, and in order to classify the tumor, first of all, by the molecular change the tumor has, and then subsequently see what kind of treatments can be used, and then see, okay, does this treatment in this particular setup make sense or not? So just getting as deep as understanding as possible on the tumor, and I think we can all agree that diagnostics is the fundamentally first step on a treatment decision. Generally, again, why genetics in tumor? When we look on a tumor, what we could see is, or what we can define is, that tumor, you could say it's a genetic disease because we have a cell, that cell has a certain type of damage, the damage got not repaired correctly, and then subsequently it starts growing because it incorporated too many molecular changes, too many of the pathways are dysregulated, and the tumor simply starts growing. Subsequently, most of the times when it comes to tumors, we have genetic instability, and in this picture depicted, we start off with the red cells, we get additional variants in this, we have the purple cells, and then a subgroup of the red cells again has accumulated different kind of mutations and get a different tumor population depicted here in blue. Some of these tumor populations might actually acquire variants that are not sustainable for the tumor, so this part of the tumor could also be itself moving from the system. So there's a lot of genetic diversity within this individual tumor. So when we understand what the tumor has, when we understand what the tumor is driven by, we actually have much better chances to make a diagnosis, to make a prognosis, to select for certain drugs, for certain treatments that would fit to the molecular changes within the tumor. Again, coming back to personalized precision medicine. Okay, so we were thinking about, okay, what can we offer here? Because we want to offer something that is helpful for the individual patient. And therefore, we came up with mainly 3 different services we are offering. The one we call Cancer Precision. Cancer Precision is, and I will go a lot more in depth on that one, is a comprehensive diagnostic for targeted cancer treatment decision. So we here make a full molecular investigation on the cancer in order to identify which are the changes that can be targeted. We have with Cancer Neo a neoantigen prediction setup, which is a first step for personalized cancer vaccination designs. And this one is, as the name says, used when we have these targeted, the goal of this treatment here is to create something that specifically targets the cancer in form of a vaccine. And we need to understand a lot more on the passenger mutations than when we look for treatment decision. Another aspect we do see here is that when we look for patients which have a tumor that can be hardly removed, when we're looking for liquid biopsy samples in different setups, that the sensitivity of a standard NGS approach in some cases may not be sufficient, and therefore we developed with Cancer Detect a service that focuses very much on the actionable genes from liquid biopsies with an extreme sensitivity in order to detect these low abundant frequencies, the frequent variants from the bloodstream. So let me start focusing on Cancer Precision, the first one. As I mentioned before, the goal here is to characterize the tumor in depth. So we want to understand what is driving the tumor. What resistance mechanism does the tumor has already acquired? What is happening here in depth so that we can choose a treatment? And we think that this service offer we have here is the best choice for nearly all cancer patients when it's a first-line diagnostics and genetics here. We're looking here on a panel that has a dedicated of 766 genomes on it, and we're looking on DNA level on selected translocations in 31 genes. We'll come also to that a little bit later in the talk, why on DNA level detecting structural variants might sometimes be complicated. We are always looking at a tumor normal tissue comparative sequencing, and I will go a lot more into depth on that one, why this is so important to do a tumor normal tissue comparison. I mentioned before that we design our enrichment kits, our lab processes ourselves. And one of the benefits you see in the next line when we're looking for sensitivity on a single nucleotide variant, and we actually get a sensitivity of 99.9% detecting a heterozygous single nucleotide variant, even when we have a tumor content of 20%. So we have optimized this in the couple of generations we did on the enrichment dramatically. Immune checkpoint inhibition is one of the most used targeted treatments today. And to markers to do so is the tumor molecular burden, microsatellite instability, and also homologous recombination deficiencies are very valuable scores for determining these kind of treatments. And obviously, these are an integral part of our analysis. But then we moved on and said, okay, these are fundamentally what needs to be done, but what can we also do? And one of these is that we actually look for viral integration events on the HBV and EBVs. We're also looking on pharmaceutical toxicity. For example, a DPYD variant can inhibit or can be toxic when using 5-FU treatment. And as structural variants are also quite common in cancers and have a great impact on treatment, we are offering an optional RNA-based fusion transcript analysis of 106 genes. And again, I will come to that a little bit more in depth in a moment. But let me start off with why it is so important to have tumor normal tissue comparative sequencing. In order to determine the true somatic variants on the tumor, we need to understand, first of all, we need to understand that each and every one of us has about 40, 50,000 variants, which we just have, and they don't make us sick. They're just the variants that determine a little bit who we are, a little bit how we look like. And we need to distinguish these variants from the variants that are specific on the tumor. When we then look at this as an approach, what we do is we sequence the tumor and we look on the allele frequencies. That means how often a certain variant is called on that particular position in comparison to the other reads which don't have that. When we look, let us first start with the germline setup. When we look on a heterozygous variant, what our expectation is that about 50% of the reads have the one, have, let's say, an A, the other 50% have a T at that specific position. When we look now on a somatic variant, things get much more complicated. We have a mixture of tumor cells to normal cells in every case. And when we have, let's assume, 50% of our sample being tumor cells, and these tumor cells all have a somatic variant at that specific position, it is very hard for us to distinguish if these 50% of the reads we see with the alternative variant are actually coming because the whole body of that patient has a germline variant, or it's a tumor-specific somatic variant. And this results when there is a tumor tissue-only sequencing in these faults. Let me 1 second. I want to have a laser pointer here. Thank you. When we look at this one here, this one actually is a false positive call here, because actually it would be a germline variant, but it is called as a somatic variant because we have a high tumor content in that particular sample, and it's very hard for us to distinguish these two. When we look on a tumor content that is dramatically different to the normal tissue, we can actually be sure that if we have 50% of the reads, that it's very likely, at least, that this is not a somatic variant, but it is a germline variant. So then it can be excluded. So actually, what we would normally love to have, a high tumor content, is not always beneficial on a tumor-only sequencing. So this is just a little bit shaky when it comes to distinguishing tumor sample variants from the normal tissue variants. And so unprecise diagnostics is something we don't think is a good approach to do when going on something delicate like choosing a treatment. So these algorithmic determinations on only one tissue sample are possible, of course, but they have the risk or bear the risk of false positive results, and thereby changing a lot of the characteristics. When we look on a tumor to normal tissue comparative sequencing, the setup is very, very easy from a bioinformatic point of view. We basically sequence the tumor, we sequence the normal tissue, and we can simply make a subtraction and understand which are the true somatic variants in that particular patient. Obviously, on the other side, it's very demanding on the laboratory aspect because we have to do two sequencings, 2 enrichments, and do the whole process. So it's just more consuming on the laboratory part. But, and there have been a lot of publications out there, it's the safe way to determine true somatic variants and distinguish them from germline variants. One of these characteristics when we do that immediately come out is the so-called tumor mutational burden. With tumor mutational burden, what we're looking into is how likely actually it is that the tumor cell presents genetic or altered peptides that could be targeted by the body's own immune system on the cell surface using the MHC complexes. Fundamentally, we start off with having genetic variants on the DNA level, which, with a certain chance, change protein sequence And this changed protein sequence is then when the proteasome breaks down the protein and it's cut into peptides with a certain chance then loaded on the MHCs. The MHCs present this to the cell surface, and the body's own immune system can come by and detect these as wrong and can actually target the cells. And then we have the PD-PDL1, PD-1 interaction that calms down the immune system. This is a very stochastic approach. If we have a high number of mutations, it's more likely that a certain number of peptides are presented, and that means it's more likely that this approach will work. But we need to understand in depth and in detail how big these chances are in order to make a safe decision. So what we need in order to do so is, first of all, we need a sufficiently large coding region, and that is a publication by Buchholz from 2018 that says we need at least 1.5 megabases of coding region as part of this determination. Otherwise, it's just not sufficiently accurate. It's quite easy to see that. We're looking into something like distinguishing 8 somatic mutations per megabase from 15 mutations per megabase or 12 mutations per megabase. And when you have something as a target region, which is only half a megabase in size, and you actually have to look that the tumor driving mutations are not part of that setup, what we actually end up with, you have like 2, 3, 4 mutations as an expectation. And you can easily see that if you have a stochastic based on that one more or less variant makes a big difference here. If your coding region is sufficiently large, one additional sequence will not make that big of a difference, and therefore we can safely determine the tumor mutation burden if it's high or low. One other marker is homologous recombination deficiency. That is virtually like the follow-up on the BRCA phenotype. And here also we look on a global scale on changes. We look for loss of heterozygosity. We look for large-scale transitions, and we look up the number of telomeric allelic imbalances, and we determined that also in-house. We looked a lot into the determination of the scoring threshold, and we will give this as a threshold marker, and you will see that in a report like this, where you have the patient here marked with 53, which is clearly a high HRD score, which is on the higher part even for B allelic inactivation as a comparison. So this is again something which needs a sufficiently large data set in order to be done accurately. So these were like markers. We're looking more on the global scale, but then obviously we are looking on the individual sequencing variants on each and every case. And one of the results that would be handed over in our reports is looking like something like this. In this particular patient, there is one germline variant, and that already shows you that the germline is not only used as a control tissue in the bioinformatic part, but it's actually also part actively in the investigation, because germline variants can have, like in this case, checkpoint inhibition sensitive effects with an evidence level of 1A, so which means highly selective for the specific biomarker and for the tumor entity we're looking here. So the germline, to look into the germline actively, is part of this process. But then we have as well here other markers, other variants that are part of the recommendations or part of the options for treatment in that particular patients. And you see there's copy number variants, like for CDK4, we have an amplification, at least 10 copies. It's a CDK4/6 inhibitor sensitive, and this list goes on. And you can actually then say, okay, based on these results, I do have a couple of options to treat my patient. And then you can see what other markers are there for the patient, or what other needs are there for the patient, which is available. And then you can choose a treatment appropriate on that setup. What we find that is very, very valuable in understanding a little bit the pathways on the tumor is our pathway illustration. And this is one example here, where you see you have, like here, the P10 depicted. You have different genes or target areas marked, and they can be marked either in blue, that this gene product is inactivated, in red that it's activated, and in brown that there is a functional change. And then what we can do, or what you can do actually, is when you choose a treatment and explain that treatment to the patient, you can actually explain why, when there is a P10 inactivation, an AKT inhibitor, which we don't have in this one, sorry, might be a potential target, because the P10 normally inhibits the activation of AKTs. So you can substitute this potentially with an AKT inhibitor. So this is something that we found as a very interesting aspect in choosing, in explaining the results to the patients and understanding. So I mentioned before that structural variants are quite complicated to be detected on DNA level. And let me elaborate a little bit on that. When we're looking for structural variants, we start off with something like this. So we have a gene A, and we have a gene B, and then here's a structural event where these two exons with a little bit of the intronic regions are integrated between exon 5 and 6 on that particular gene. And the subsequent resulting genomic area looks like this. So we have something like a part of the intron of gene B, then part of the intron on gene A, the whole exon 1, exon 2, and then we have another breakpoint here, and then it goes on with exon 6 and 7 on the other gene. And then subsequently, what we would end as a gene product is we start off with the start codon here in exon 1 gene A, and we get exon 1, 2, and then from gene B, 6 and 7, and that could actually have a dramatic effect on the resulting protein, if that makes a stable protein. In order to look at this on a DNA level, we're not quite sure. It can actually, breakpoint can be anywhere in this intron, can be anywhere here, and it can integrate anywhere here. It doesn't really matter for that purpose of getting this product. But we would actually need to sequence all of this area, all of this area, and all of this area in order to have a chance to see this breakpoint. So this would blast or would boost up dramatically the region we will have to sequence, and because we need to sequence on a somatic analysis level, something like 500 to 1,000 times of the target region, this dramatically increases the price tag of such an analysis. But when we change that and we say, okay, we know that there might be exon 1, exon 2 of gene A, and then starting on with exon 6 and 7 from gene B, we know the sequence of these exons. And so when we focus on this breakpoint here, where it changes from gene A to gene B, and we look on reads that span specifically over the breakpoint, we actually know what we're looking for, and it doesn't really matter where it's integrated, but we actually can determine that in detail. So when we do that on DNA and RNA level, the exact breakpoint is not mandatory to understand, but it's quite challenging to do a specific design on that. So what we did here is we established an RNA-based structural variant add-on to the analysis that specifically targets 106 genes, which are known to be involved in treatment decisions for structural changes on these DNA levels, and integrated such an enrichment and such a sequencing into this. So that's an on-top service that we can offer on this cancer precision analysis. One other aspect we are offering is Cancer Neo. I mentioned that before, and I will go very briefly over it and will not go into much depth here. And this Cancer Neo is the support of the design for a cancer vaccination in order to boost the body's own immune response to cancer cells. So virtually handing out the wanted signs for the specific neoantigens on the cancer. In order to do so, when you remember how the tumor mutational burden works in principle, in order to do so, what we need to understand is not a stochastic approach, how likely it is that that generally altered peptides are presented, but we need to understand each and individual potentially displayed peptide. So what we need to do is we need to sequence the whole coding region of tumor and normal tissue to identify the somatic changes in the specific tumor patient. We also want to understand, is that altered somatically altered gene actually expressed? So we do a tumor whole transcriptome sequencing. We need to understand the HLA typing for each individual patient so that we can then make a prediction which of the somatic altered peptides are actually then potentially loaded on the MHCs and are presented to the body's own immune system. And we have made a lot of effort to identify what is a suitable approach to do so and how can we determine the most likely and their best targets on the specific neoantigens. The last service I want to go a little bit more into depth is Cancer Detect, because I really think it is an astonishing service that has extreme potential. So the idea here is to utilize liquid biopsy as a sample. And yes, we can use liquid biopsy on a cancer precision sample, and we can do the full molecular examination of that sample. But it has one limitation: we need a certain amount of tumor content in that sample. So generally speaking, we need at least 20% of the DNA being derived from tumor. When we look at liquid biopsy samples, this most of the times only holds true for patients which have a very high tumor load, are in very bad conditions already. When we want to boost the sensitivity here, what we need to do is we need to do a lot more effort on the sequencing side. So we're sequencing here with a raw coverage of 50,000x, so approximately 100-fold more deep compared to a standard NGS, or well, not even a standard, but a high sensitive NGS approach already, which we're doing normally. So we have a dramatic boost in coverage that is needed on the laboratory side. And then we actually need to compensate for laboratory processes. And this we're doing using unique molecular identifiers, where we marked each individual DNA to start off with. And the price for that is that we have to restrict the analysis to hotspot actional driver mutations in 36 genes. The benefit is that we boost the detection of allele frequency detected from 5% to down as low as 0.25%, so 20 times fold increase in sensitivity. And when you look on the report, it looks very similar to our cancer precision report, at least for these potentially therapeutic relevant targets. We have here an EGFR missense mutation, which shows an allele frequency of 0.4%, or a TP53 missense mutation with 0.86%, so very low frequent variance. But having such an offer actually allows us to utilize that in different kind of strategies. One of this is to have an early detection of reoccurrence. So we have here a patient, and this is the tumor-associated genetic. So virtually, how often do we see in the liquid biopsy the particular variant? So we have to determine first the particular variant that we are looking for, and then monitoring this over time. And what you see is the patient gets surgery, it drops down, the patient is then treated, and the treatment response is very good. So the tumor shrinks, the tumor shrinks, the tumor shrinks, and we're undetectable on the liquid biopsy on the specific variant that is unique for, well, not unique, but it's like in the body, it should not be anywhere else than derived from the tumor. And then the patient is treated on, and we are monitoring. At a certain point in time, we start detecting the particular variant again. And then we can raise our hands and say, wait a second, even so the patient has been treated, or maybe the treatment was stopped, there is a potential reoccurrence happening. And this can be much more sensitive than doing an MRI every 6 months, because we just can do that. It's an easy blood withdrawal, and you can monitor and have an early detection on such a relapse. The other setup, which is very interesting, is detection of certain drug resistances. One of these examples would be the EGFR T790M mutation, which is one of the most common resistance mechanisms for tyrosine kinase inhibitor therapy in non-small cell lung cancer. And what is done here is you virtually see you have a treatment and this particular variant is going down, but then at a certain point in time, the previously not known or previously not existing T709M mutation on the EGFR is occurring, depicted here in purple, and then we already have, even so, the tumor might be generally still shrinking, but a certain subset in this tumor already developed the resistance mechanism is coming up. We can already at that point raise our hands and say, careful, careful. We have detected the T790M, and we might need to switch to other tyrase kinase inhibitor targeted therapies. So we are, as you see, general goal is to just be early on in the detection and to optimize treatment strategies for the individual patient. And this actually, I think, is a slide that will then very nicely hand over to Saskia's part of the talk, is how can we see that this could be combined in patients' treatment, and how can we assist and accompany patients to their journey in treatment. So first of all, we start off with a patient that gets a general genetic diagnostic like our Cancer Precision based on a biopsy sample. Then during treatment, we monitor depending on the treatment, for example, with Cancer Detect. We then have a patient that could be considered disease-free, and we monitor for reoccurrence. And then if we have a reoccurrence or disease progression, we go back and say, okay, let's do a full molecular examination on that particular patient in order to understand what has changed and what are our new options to treat the particular patient. So with this, I am through with my part of, oops, this was not what I intended to do, I'm sorry. So with this, I'm through with this part of my talk. Thank you very much.
So thanks a lot, Stefan, for this very broad and comprehensive overview. So now I would like to follow up on this introductory talk, and I would like to talk about how we can integrate all these tests into patient care. And I not only talk about genetics, but diagnostics. So I will not only speak about the genetics, but maybe also a little bit about the future and what we already do in this direction. So most importantly, and this is why I'm very grateful that you're all attending this afternoon session, we have to work together in the best interest of our patients. And I think no single doctor is able to really have all the knowledge at the same time. So we need to work in interdisciplinary teams. And I think you have us as partners for the genetics part. And in the end, what we want to do, we want to make the life of our patients better. So I want to thank the team, because without this phenomenal team, we would not be able to do that. And the resolution of the building is not very good, but you can maybe see this is our building in Tübingen. And the good thing is that it all happens under one roof. So if a patient walks basically in, I'm sitting in the second floor with my practice for human genetics, but also in the second floor, we have an oncology practice with two colleagues, two hemato-oncologists. One also is a gastroenterologist. His name is Alexander Golf, and Thomas Okic is the other oncologist. So here in Tübingen, we are already working very interdisciplinary, let alone the big team that you can see on the picture. And I think it's very important. So I want to have a little journey now for what I'm primarily doing here in Tübingen and how we want to improve even the tests we are providing at the moment. From a general perspective, what we want to do is we want to do precision medicine, and precision medicine is the future in my eyes. So personalized is maybe today, precision is the future. And the three pillars we have is precision diagnostics, and obviously CGAT plays a huge role in precision diagnostics. Then the interdisciplinary tumor board meeting that is meeting basically every week, sometimes more times a week, where the test results are discussed and then the treatment is suggested to the patient. And then the third pillar actually is the implementation of the therapy. And then, like Stefan already explained, that monitoring of these decisions is crucial. So when a wrong decision is taken, we have to know soon, and not after 3 months maybe, or after 6 months. And we should not forget that the patient also has a huge role in this. So when I try to explain to you what we need in our patient care, I think it becomes increasingly more important to have a part where we guide and navigate the patient. So we have to explain the diagnostics to the patient. We have to get the informed consent. Then we are having the tumor board meetings. The patient wants to know when the tumor board meeting is taking place. We have to explain the results. We have to explain the treatment that we would like to implement. So this is a circle around the patient, and we should never forget that. Then we need state-of-the-art technology. And Stefan already mentioned that quality has been always very important to us. And the technology we are using, the Illumina NovaSeq machines, you can see on the right upper panel, but also we are introducing new technologies like the 10x Genomics platform, where we can do actually single-cell transcriptome sequencing. On the right side, you see the Milteny Maxima machine, which is a imaging technology where you can actually look at hundreds of antibodies on one slide, and in the middle, a Tito machine where we are able to extract T cells from the blood of the patient and then sequence T cell receptors. So I will come back to this later. Our milestones you have already seen. I want to mention it again because I'm sure you know, but quality comes with a price. And I think the challenge we have is what we want to provide the fastest and the best test, but still with the highest possible quality. So this is difficult to implement, but this is what we want to do. And I think this goes hand in hand. And so this is what we try to provide to you: a very fast, a very high quality test. And then in the end, it should be with you for an affordable price. Genetics today, and I'm now talking about my experience of actually thousands of tumor boards I've been in the past years. And the tumor boards take place once we have received the genetic results, and the reports that Stefan has shown to you, you now recognize several markers that we look for, but you might wonder what is most important in a clinical setting. So what is most striking in these reports we are providing? And I can tell you from my own experience, the first thing we always look at is whether there's a germline variant. The germline variants are crucial, especially when you make treatment decisions. I come to this, and then I will again speak about the clinical implication of the tumor mutational burden and microsatellite instability. I will give you an example on the relevance of homologous recombination deficiency, and then briefly talk on driver mutations and fusions, and also pharmacogenetics. The germline, why is it so important? When a patient comes to you and has the diagnosis of cancer, the majority of patients want to know where the cancer comes from. And it's really striking that if you look that in every fifth patient, and this is not restricted to a single tumor entity, but it becomes clear that this is beyond what is published in 2018, because we now see that every fifth patient actually has a pathogenic germline variant. So the majority of genes that are inherited and are resulting in cancer are genes that are involved in DNA repair, either homologous recombination or mismatch repair. And so this is something that I think when you are familiar with, for example, PARP inhibitor therapy or checkpoint inhibitor therapies, when you see a germline variant in one of these BRCA1 and 2 genes, or PARP2 or ATM, ATR, and so on, you immediately want to see whether you have the signature in the tumor, and this is what we provide as well. So we give you the marker of the homologous recombination deficiency so that you can see that the tumor actually has the signature, and we know that this is the cause of the tumor, and also the Achilles heel of the tumor. So this is then the major feature of these tumor cells, and it's also guiding our therapy. The same with mismatch repair. If there's mismatch repair, in the tumor, then we know that these tumors are highly immunogenic. So when we see this, and this is the major marker, we should not consider chemotherapy, but we should think in the direction of immune therapies. If you look in the New England Journal of Medicine, you find a recent publication on breast cancer risk, and it's interesting. You don't need to see in detail, but what it shows is that it's not enough to look for BRCA1 and 2. So there are many more genes that are involved in DNA repair that gives a risk for breast cancer. And so if you do testing only for BRCA1 and 2 and you don't see anything, that's by far not enough. The next important point, like Stefan was already mentioning, is the tumor mutational burden, or another marker, microsatellite instability. This is an image that has been shown, I'm sure, 100,000 times from a paper from Alexandrov in 2013. It shows the tumor mutational burden in various types of tumors. And if we look at the marker 10, so 10 mutations per megabase, you see that the majority of tumors actually have less mutations than 10. And when we go above 10, these are tumors that are responding to checkpoint inhibitors. And the overall amount of tumors that would respond to checkpoint inhibitors are only 30%, and 70% would not. But it's crucial to know this marker in each individual patient. Imagine you have a patient with a rare tumor. For example, I recently had a chondrosarcoma patient, and you would never expect that this is a mismatch repair deficiency, because usually sarcomas are tumors that have high numbers of copy number variants. But then when we noticed that this tumor was actually caused by a mismatch repair defect, this patient was immediately taken from the chemotherapy and was shifted to checkpoint inhibitor therapy. And in this patient also, a mismatch gene was defectively inherited, and so that was also the cause. And this patient is now doing fine since several years. What I want to tell you is that even if you have a rare cancer, especially in these situations, cancers of unknown primary, you should check this marker. And then when you look at these different tumor entities, you see, when you look for glioblastoma, for example, in glioblastoma patients, it's rarely happening that you find a mismatch repair deficiency, but these patients exist. And I have seen, since I have a focus on GBM patients, I've seen this several times. And these patients actually do quite good with immune therapies, and it would be traumatic if these patients do not get access. So even rare, this marker has to be tested. And you might also think that GBM or glioblastomas are not inherited cancers. That's not true. It's not yet published, but it's already known in the community that every fifth patient with a glioblastoma has an inherited cancer. And so when you're treating this patient, you have to not only focus on treating the brain cancer, but you have to make sure that these patients also receive colonoscopies on a regular basis, because they are at high risk for colon cancer. And so the family members have to be tested. So this is just, you have to look beyond the GBM that you're treating in this patient. The same with pancreatic cancer. Pancreatic cancer is a difficult to treat tumor entity, and you know that there are only 2 or 3 therapy lines consisting of chemotherapy. But you should know that every 5th pancreatic cancer is driven by a DNA repair defect, like homologous recombination deficiencies. And these patients should get access to platinum-based chemo or even maintenance therapy with PARP inhibitors. But rarely, I have also seen pancreatic cancers that are driven by a mismatch repair defect, and these patients do very well with checkpoint inhibitors. And so what this graph shows you is that basically every tumor entity can have tumors that are driven by either mismatch repair deficiency or homologous recombination deficiency. So this is why it's so crucial not only to know the germline in each individual patient, even if the family history is non-informative, meaning there are no siblings or no cancer described in the family yet, but you have to know whether it's inherited, because it has a therapy consequence, you have to find out whether the tumor mutational burden is beyond 10. 10 is an established marker that we use for not only melanoma and lung cancer, but broadly. You have tumors that are hypermutated, and then it's pretty obvious, like in bladder cancer or melanoma, but there are many other tumors, as you can see on this image, that are also having a high tumor mutational burden. And what you also have to know is that microsatellite instability and tumor mutational burden are two independent markers. You can have a tumor that has a microsatellite instability due to mismatch repair, but that does not necessarily have a tumor mutational burden that is above 10. Still, checkpoint inhibitor therapy should be discussed, and you have tumors that have a high tumor mutational burden, but without microsatellite instability. So just be careful when you use these terms, and you should always, for every patient, have both markers. Next point, copy number variance. Stefan was already referring to this, and I think it's important to know that there are different types of genome instabilities. But I want to specifically focus now on the homologous recombination deficiency and why it's so crucial that you get this marker in every of your patients, because it has such a dramatic effect on how you design the treatment strategy. Let's look at homologous recombination deficiency. This is a picture that shows you on the left side the whole different complexes that get recruited when the double strand breaks. And on the right side, you can see that they are in different categories. So there are sensors that basically sensor when there's a double strand break and get recruited. And then there are effectors of the resection complex, transducers of the mediator complex, and later on you have the repair. And so you see already that BRCA1 and 2 occur in this list, but they are by far not the only genes that are involved in homologous recombination deficiency. So looking at BRCA1 and 2 only would not be sufficient. And if you, for example, have done a pre-test for BRCA1 and 2 and that was negative, you should question whether there might be some additional genes that have mutations that could be either somatic, meaning that they are only in the tumor, or inherited, but show a high homologous repair deficiency marker. Stefan just explained this to you. When this marker shows that there's a deficiency, an underlying gene mutation of all of these genes could be implemented. And then it's so important because treatment can be designed with this knowledge. The homologous recombination deficiency is basically shown by 3 different markers in particular that Stefan also explained: the loss of heterozygosity on the far left side, the telomeric allelic imbalance in the middle, and large-scale state transitions on the right side. So this is basically a signature in the genome of the tumor that you cannot see from the normal tissue, but you see it in the tumor. And it happens if one of the genes that I showed to you is affected by mutations and is not working properly, then in the end, the DNA is damaged. If a tumor has a problem with DNA repair and is damaged, the tumor has a problem to replicate, and that causes stress to the tumor. And the concept of synthetic lethality is maybe known to you because you are familiar with PARP inhibitors, but it basically shows that when you know that the tumor has a problem in repairing, you can put an additional stress on the tumor. So you can use platinum-based chemotherapy and induce more double-strand breaks, and then at the same time you take away the enzyme PARP, which is helping the tumor to overcome this deficiency. And so by using a platinum-based chemotherapy, you induce more double-strand breaks, the tumor has a problem to repair, and then undergoes death. And this is called synthetic lethality, especially when you on top take away the enzyme PARP, which is an alternative repair way that the tumor tries to rescue its problem. Okay. So driver mutations, you know, are crucial. Stefan mentioned the EGFR, but there's so many other drivers, BRAF, KRAS, and pharmaceutical industries are heavily working on identifying treatment that is targeting driver mutations. So we need to know all drivers, and we need to know them all means that when Stefan showed you the picture of the whole cell, we can't only look at one side, we have to look at the full picture. If a mutation is upstream and you have another mutation downstream, it doesn't make sense to inhibit upstream. So this is something that you have to keep in mind, that if you do a short analysis of only 3, 4, 5 genes, it might not indicate the whole picture on what is driving the tumor. And sometimes, and that is also problematic, the tumor is driven by several different driver mutations. And in the tumor board, it's a very difficult situation because let's say you have a tumor that is driven by EGFR, has a loss of PTEN at the same time, and also loss of CDKN2A and 2B, then you have to prioritize. And I think the worst thing that can be done from a genetics perspective is that you focus on one treatment. If you say, okay, I can only afford an EGFR inhibitor, but PTEN is lost downstream, then you should know that mTOR most likely is activated, and if you don't block mTOR at the same time, the tumor will escape. And so when you especially have a long list of driver mutations, it's crucial to have these tumor board discussions in order to find out what is primarily driving your tumor. And also you have to then design a combination of treatment focusing on several drivers at the same time. And here we are working on the immunohistochemistry, like I mentioned, with the Maxima platform, with staining of antibodies through antibodies on the tumor slide. We try to identify not only the heterogeneity of the tumor, so you can also imagine that parts of the tumor can be driven by EGFR and others are maybe primarily driven by another variant. If you don't consider that the tumor is composed of different types of driver mutations, that you might be too short-sighted if you focus on one, because then you select for the ones that are resistant because they don't because they are not driven by this particular mutation. With fusions, it's another story, and I think Stefan provided our test or explained our fusion transcript analysis to you. Why did we spend so much time to develop this extra test? Because I told my team, I don't want to have a single patient where you overlook a fusion. And why is this so crucial? Why should you never overlook a fusion? If a tumor is driven by a fusion, it's the main driver, and it makes it as a perfect target for treatment. Let's say you have a tumor where you overlook an NTRK fusion that you do not know because you don't see it, and then you don't target it. You can be sure that 100% of these tumor cells are driven by the fusion, and so you need to know the fusion. And this is our motivation why we developed this test. We don't want to have a single patient, even if it's a rare event, we don't want to overlook it. We need to know. Now, in the last minutes, I would like to have a journey with you into the genetics of tomorrow, because what we not only provide to you is the most comprehensive test of today, so that you get every marker, TMB, MSI, germline, HRD, every driver, every fusion in every single patient of yours. We want to develop the methods of the future. And the future, of course, consists of a lot of genetics, which is whole genome sequencing to see structural variants, whole exome sequencing. Stefan mentioned that we are focusing on neoantigens in especially when we determine the neoantigens for cancer vaccines. We sequence from the cell-free tissue, like in the spinal fluid, the urine, ascites, every fluid you can bring to us that potentially contains tumor DNA, we can sequence. We sequence the whole transcriptome to understand what is driving on the transcriptome level, and all these other technologies, T-cell receptor sequence and so on, that are to come, including the microbiome. So just coming back where we are at the moment. So I want to describe to you our most recent publication where we try to show the concept that we are using, but it doesn't matter what type of tumor this is. You can look at this, what I'm presenting to you, for every of your patients. It could be a patient with breast cancer, it could be a patient with prostate cancer. The way we approach this is always the same. And this patient I'm describing to you now is just published, and you can read it if you want to. If you're interested, you can get the PDF from us. Just let us know. This patient, when I saw this patient first in 2015, the patient was at the end of his therapy with a high risk metastatic urothelial carcinoma. And when I saw the patient, his doctor said, now we are done with the chemotherapy, and unfortunately we can't do anything for you, so you have to basically go home, and that's it. 2015, we already sequenced the whole exome and the whole transcriptome in this patient, and we identified a high TMB of 41.2, meaning every 1 million positions of the genome, we found 41.2 mutations. And you remember, I told you that 10 is somehow our marker that we have in mind, and it's far above 10. So at that time point, we went to the physician, Professor Stenzel here in Tübingen at the university clinic, and we said, look, this patient needs to get access to a checkpoint inhibitor. And at that time point, a checkpoint inhibitor was not approved for this tumor entity. But we said we need to get access, and we call it off-label if we get access to a treatment that is not approved for a particular entity. And that was really impressive to me, because when this patient got the first infusions of pembrolizumab back in 2016, the lymph nodes that were actually in his neck, and he could barely breathe and swallow, they just disappeared. And that was revolutionizing to me. And you know that the Nobel Prize was given for this finding in 2018. So basically 2 years later, when this patient already benefited. The patient is doing fine. If you want to ask me this, he's tumor-free today. But what we did and what we are still doing, I want to show you. So we did this extensive sequencing for this patient. We had weekly tumor board discussions, because we were in completely new land, medicine, at that time point. And basically we are all this with every patient now, basically every day as well. And we implemented a precision therapy for this patient. Not only that he got access to a checkpoint inhibitor, we designed a personalized vaccine for this patient when he got side effects from the checkpoint inhibitor. And here you see one image of the publication, and you should focus on the left side. You see when this patient started pembrolizumab, we also started the liquid biopsy for particular mutations we knew from the tumor. And whenever the line is very down, it says 0 droplets. We used a digital droplet PCR to look for specific mutations. There was no tumor DNA detectable. He had to stop pembrolizumab because of the side effects. He got skin reaction and couldn't tolerate it any longer. We started the vaccinations, and then unfortunately he also got side effects, and he got an allergic reaction, and it indicated that we generated a very strong T-cell response. We had to stop the vaccine as well, but we still monitored the liquid biopsy by the digital droplet PCR. And then you see on the figure that the droplets started to increase. We had 3 droplets, then 10, then 144. We went to the clinician and said, look, you have to do imaging. There's something going on, we are sure. And the patient just had a tiny little lymph node that we didn't actually know whether it's cancer or inflammation, but because of the digital droplet PCR, we knew 100% that this is cancer. So we said, you have to start pembrolizumab again. And this is when you see that the positive droplets immediately disappeared and go back to normal. And we do the droplet PCR every 3 weeks, and the patient is without tumor DNA in the blood and without symptoms and is leading a normal life. So at the same time, we needed to know what is going on with the immune cells. And Therefore, we did what we call immune monitoring. So we look for neoantigen-specific CD4 and CD8 T cells in the blood of this patient. Through the vaccine, we are able to create a specific immune response towards tumor mutations. And so the whole procedure of generating a personalized vaccine, I don't want to go in detail, but you do a biopsy, you do sequence analysis, whole exome and whole transcriptome sequencing, HLA typing, and neoantigen prediction. Then you produce the personalized vaccine, you vaccinate the patient, and then every 3 months we do immune monitoring, meaning that we culture T cells, stimulate them with the neoantigens, and measure whether the T cells recognize the individual mutations. And this is also a figure that you can find in our publication. The darker it is, you don't need to see it in detail, the stronger the immune response is. And you can see that we look for CD4 and CD8 T cells. On the left side, you see the peptide sequence that contains the particular mutation, designed according to the HLA of the patient, which is necessary that the mutation actually is presented to the immune system. And you see over time how strong the T cell response was in this patient actually before he reacted allergically, and we had to stop. Another thing that we work on is the microbiome. So when we see patients on a regular basis, we are interested in the microbiome. Why is this the case? The tumor is one thing, the genome of the tumor. The immune system I just mentioned is another important component, but the microbiome is where the immune system is getting close to the T cells in the gut. So we need to understand the microbiome as well. And this is why CGAT is working on presenting the microbiome data to each individual patient. And this is just a timeline where a patient just delivered a microbiome box to us, and then we look for the diversity, and then you can see how this differs over time. We look at certain parameters, and we are specifically interested in how this is affecting by the chemotherapy. So this is a patient, and you can see only the shifts. You don't need to look in detail, but you see exactly, you can tell just by looking at this picture when the patient stopped to take chemo, because the microbiome changes immediately. And so we have to understand which germs actually are in the gut, influence the T cells, and by this influence immune therapies. We have to also look at pharmacogenetics, and pharmacogenetics is also crucial in the tumor board, and we provide pharmacogenetic information to our patient because for some chemotherapies, you need to know, and you have a list here, you can look on our homepage if you are interested, but especially sensitivity to irinotecan or other chemo components that are crucial to know in advance before your patient gets toxicity. Now we have the situation that a patient comes to us, we do the testing, we find the variants, we provide them to the physician and say, look, you have to be careful, but the physician tells us, oh, yeah, I realized the patient had a lot of toxicity and we had to reduce the chemo, but I'm questioning, why aren't you doing this in advance? Why don't you want to know in advance whether this could increase, whether this could induce traumatic toxicity in your patient? Coming back to this, assembling pieces of the puzzle. So what I wanted to illustrate to you is how we implement our diagnostic testing in the clinical routine, how our patients actually benefit from what we do. I want to illustrate to you again that you should not just look at one specific marker. If you have a patient with pancreatic cancer, you say, oh, I already know it's driven by KRAS. Why do I have to do something on top? Yes, you do have to do something on top. You have to know whether this is one of the rare pancreatic cancers that is driven by mismatch repair, and you need to see that. And yes, you need to look for homologous recombination deficiency, because you should not overlook if this is a patient that can benefit from PARP inhibition. And then I want to say that we do not rely on genetics only. We already look beyond genetics. We are interested in immunohistochemistry. We are interested in T cells and how they attack the tumor, especially when your patient receives immune therapies. We look at the microbiome, and we further try to develop our tests in the best interest of your patient. So Holy Grail, and we had this question already before, is early detection. At this point, I have to honestly say, if you are healthy, you will not be able to use our methods in order to find whether you get a tumor or not. We use liquid biopsy only to therapy monitoring at this point. I'm sure this will come, but it's not yet usable. And the reason is if it shows a negative test, you cannot be sure that it's really negative. So be careful. But maybe in a few years, hopefully, this will be a good method for early detection even before you get sick. And with this, I would like to summarize. It's an interdisciplinary effort. We have to work on all these different pillars, and we have to get better and better. And most importantly, it's because we collaborate and work together. Then we close the session. All the best to all of you, and talk to you soon, hopefully.
Thank you, everybody.
Bye-bye.